For now, we have our BMSS Aryeh Shander lectures on the first day of the conference. So we are going to have our fourth BMSS Aryeh Shander lecture entitled Treatment of Iron Deficiency, a New Paradigm. And we are very, very privileged indeed to have as the lecturer Dr. Michael Auerbach, who is in private practice hematology and oncology in Baltimore, Maryland, USA, and is a professor of medicine in Georgetown University School of Medicine, Washington, D.C., USA. So we already said this about Dr. Auerbach. I have been privileged to listen to him a couple of times in SABM meetings. And he is a professor of professors. It was from him that I gathered the confidence to use iron dextran without problems. Dr. Auerbach got his medical degree sorry about the wrong spelling of New York there, Medical College, Valhalla, New York. Internship and residency was in internal medicine at Cleveland Clinic Foundation in Ohio, and the fellowship training in hematology and oncology at Columbia Presbyterian Medical Center and Harlem Hospital Center in New York, New York. He had his research fellowship in thrombosis and hemostasis at Columbia. And Dr. Auerbach is board certified in internal medicine and in the subspecialties of hematology and medical oncology. He has authored and co-authored over 180 journal articles, books, chapters, and meeting abstracts. Most recently, these have been focusing on intra-iron supplementation in pregnancy and in patients with restless leg syndrome. Dr. Auerbach is the author of The Treatment of Iron Deficiency in Adults, Anemia in Pregnancy, and Diagnosis and Causes of Iron Deficiency for UpToDate, which you know is a very fantastic online resource for clinicians. Dr. Auerbach is a member of numerous professional organizations and is a fellow of the American College of Physicians. He is an Honorary Emeritus member of the American Society of Hematology, and he currently serves on the scientific board of the Network for Advancement of Transfusion Alternatives. And he advises the Society for the Advancement of Patient Blood Management. He is also on the editorial boards of the American Journal of Hematology, Blood Transfusion, and Expert Review of Hematology. In 2020, along with 3 of his colleagues, he participated in the first educational session ever delivered on the use of IV iron at the American Society of Hematology annual meeting. In 2016, he presented another on complete replacement dosing in an initial brief single visit. In December 2017, he was the principal author of the first prospective study of intravenous iron in pregnancy performed in the United States, which was published in the American Journal of Medicine. So you will agree with me that it's difficult to find anybody else as qualified, talk less of more qualified to speak on iron therapy than Dr. Auerbach. And so, ladies and gentlemen, I present to you the 4th BMSS Aryeh Shander Lecturer, Dr. Michael Auerbach.
Thank you, Dr. Usoro. That was certainly an amazing introduction. I'm going to make an attempt today to take you through a new paradigm for the treatment of what is the commonest malady on the planet, and that's iron deficiency. All right. So I am indeed in private practice in Baltimore medicine, and my colleagues and there are 3 of us, see 50 to 70 new patients per week, most of whom are anemic. We do 70 iron infusions per week, and we have positively impacted the lives of thousands of people who have miserable symptoms of Iron Deficiency. So when we're done today, I would like you to be able to distinguish the need for oral or intravenous iron for the treatment of iron deficiency. I would like you to be able to be familiar with the formulations, and I'm going to show you which are available in the United States and elsewhere, so we don't get confused about what are available to you. Most importantly, and I'm going to remind you that I'm going to show you this at least a half a dozen times, I'd like you to be able to differentiate the symptoms associated with minor infusion reactions from the vanishingly rare symptom of severe hypersensitivity, which can lead to anaphylaxis. And then, in just a few disease states, we're going to review treatment approaches with iron supplementation, and then you can make a decision on your own about whether or not what I am telling you seems cogent. I do promise you that everything I'm telling you is evidence-based, and when it's opinion-based alone, I will say that. So let's take a look. Oral iron has been used since the 1500s, when Sydenham put iron filings in cold wine to treat what was called the green sickness. Laud renamed it chlorosis in 1832, and he was the first to use ferrous sulfate. By the time the American Civil War came along in the 1860s, it was used to treat war wounds, and today it is the most common micronutrient deficiency on the planet. So just think for a second the magnitude of this. It affects more than 35% of the world's population and half of gravitas. It's 100 times more prevalent than all cancer combined. You'll see what it does in terms of the WHO criteria for years lived with disability shortly. And here we are more than 500 years later, using the often ineffective, but usually poorly tolerated oral iron, as our frontline therapy. So I just told you I would tell you this, there are almost 3 billion cases in the world. In every single country on the planet, it's in the top 5 causes of years lived with disability, and that's a WHO statistic, World Health. It's the leading cause of years lived with disability in lower and middle income countries, and in 35 countries around the world, it's number 1. It's in the top 3 in the United States. These next few slides are disturbing, and I believe that we are seeing this because women have been made second-class citizens by medicine throughout the world until very recently. This is using the 95th percentile to determine hemoglobin cutoffs. It is abjectly ridiculous that 12 grams of hemoglobin is considered normal for a woman. Most women in the world are iron deficient. If you take an 18-year-old girl and do a bone marrow, there's a 58% chance there will be no sustainable iron. And I did not tell you anything else about her other than she was female. This is even more bothersome. Take a look at the normal values that you see for serum ferritin and look to see where the cutoff values for anemia are. 15 is what we see from Quest and LabCorp. That is a ridiculous number because a ferritin of 30 has a 98% specificity and 92% sensitivity for absent marrow hemosiderin. Means no stores. Another bothersome slide. Iron deficiency is the disease. Iron deficiency anemia is its end stage. Look where storage iron present disappears long before anemia occurs. And iron deficiency independent of anemia is associated with a significant litany of symptoms, which we will go over shortly. So, if you are a clinician taking care of a patient and they tell you you are tired, they are tired, it's a pretty nonspecific symptom. We just published a paper, however, on the frequency of pagophagia, which is a pathological craving for ice. Now, for those of you on the other side of the pond, pagophagia is less common. I believe clay and dirt are more common in Africa and India than a craving for ice, and certainly in the United Kingdom, largely because of the availability. But almost 50% of iron deficient patients have a pathological craving for ice. Another almost 50% have restless leg syndrome to a degree that they have to get up at night, interferes with spouses, increases the exhaustion that is associated with iron lack, and that's independent of anemia. Brittle integument, I think you know about, but we'll limit our discussion of that. That's fingernails and hair. So I just want to say something. We just published in the American Journal of Hematology the frequency of pagophagia and restless leg syndrome on 1,000 consecutive non-selective patients asked prospectively on presentation if they had pagophagia or restless leg syndrome. And the number is over 50% for one or the other. When you see an anemic patient, do you routinely examine the tongue carefully? Look at this woman's tongue. It looks as if it were sandpapered. There are no papillae. If you have a mirror, look at your own tongue right now. It should have white dots covering the entire surface. They're the normal papillae. When you replace iron, and I chose this patient for a reason, you can see how the white dots come back. Now, they're still not completely covering the tongue, but you should be able to guess what this woman has. This is a patient with hereditary hemorrhagic telangiectasia, the world's second most common bleeding disorder. They are abjectly miserable without intravenous iron. It is cruel and irresponsible to use oral iron to maintain their stores. It negatively alters the gut, and there is no credible expectation that it will keep up with the losses. Intravenous iron is a game changer for this group of people with a rather difficult illness. So I don't want to leave this conversation and say oral iron should not be used. I don't use it very often, but there are indications. If you have mild, uncomplicated iron deficiency without active blood loss, it's perfectly effective. I'm going to show you there should be a new paradigm for the use of oral iron. We'll get to that in a minute. In the first trimester of pregnancy, there is no safety data with IV iron. I did not say it was dangerous, but we don't have safety data. I've treated between 7,000 and 8,000 gravidas. We have 0 serious adverse events and 0 negative outcomes with babies. And for those of you who think that there is not much difference between 0 and 1, I beg to differ. I like the number 0 and would be very disappointed if that number moves to 1. In the second trimester of pregnancy, oral iron is probably useful if the hemoglobin is greater than 10. But I will also show you some slides about delivery of iron to the baby in the second and third trimester that should make you rethink the use of oral iron. So where is IV iron indicated? Well, if there is intolerance of oral iron, which is in the majority of people, you should immediately switch to IV iron. Why put somebody through the iterations of a medication that causes significant gastrointestinal perturbation in more than 75% of people to whom it is prescribed? In the second trimester of pregnancy, if the hemoglobin is less than 10, because none gets to the baby who needs it for normal brain development, at any time in the third trimester, it is my opinion, let me make it clear here, that oral iron should be proscribed in the third trimester, which means never offered. We never do. IV iron should be front line. After bariatric surgery, where it's not absorbed and negatively alters the microbiome. In abnormal uterine bleeding, the commonest cause on earth, where there's no credible expectation you will keep up with losses. In inflammatory bowel disease, where it actually makes the disease worse independent of anemia by having a toxic effect on the gut epithelium and again, negatively altering the microbiome, promoting the growth of incommodious bacteria. In angiodysplasia, I've already told you, you cannot keep up with the losses. And whenever you have a comorbid condition with iron-restricted erythropoiesis, oral iron does not work. A perfect example of that is chemotherapy-induced anemia or anemia of dialysis. Now, I'm showing you this because I want to talk about which irons are likely to really be a game changer. I do not want to say that ferric gluconate and iron sucrose are bad irons. They work, they're safe, they're effective. But they take 4 to 7 infusions to do what the other 4 can do in 1 in 15 to 60 minutes. 4 to 7 IVs, 4 to 7 chances for an extravasation, 4 to 7 chances for a minor infusion reaction, which I'm going to show you. So don't get impatient. I promise you, I'm going to show you. It's amazing that we actually have this video. But the other 4 can be administered in a single setting, and you are done after that one setting. These are the approved dosing, and I think it's time to understand that approval for these irons have no reasonableness anymore. The actual approval for low molecular weight iron dextran, this is the product that Dr. Usoro said he has learned to use, is 100 milligrams over 2 minutes. It's irresponsible, it's cruel, it requires 10 doses to do what you can do in 1. It has no safety or efficacy advantage, and it costs much more because visits are not free. Ferumoxytol is approved to be given in 2 doses. You can give it in 1. I've published it 7 times. There's no difference whatsoever in safety or efficacy, and that includes pregnancy. Ferric carboxymaltose is different in the United States than it is on the other side of the ocean. You have a 500 and 1,000 milligram vial, which makes it far more felicitous to administer as 1 dose. But for some reason in the United States, we have a 750 milligram vial. It's an expensive formulation and it requires 2 visits. It's not the end of the world, but it's certainly easier to do to give 1,000 at once. And which makes it far more felicitous. Why am I hearing myself as an echo? All right. And ferric dirysomaltose, the newest formulation, is the only one actually approved for total dose infusion. But as I just told you, approval doesn't really matter. These drugs can all be given as a single one-time dose. We use a fair amount of ferric dirysomaltose, giving 1 gram in 20 minutes. Adverse events occur. But now it's very important that we define them. Oral iron causes constipation, metallic taste, nausea, gastric cramping, and thick, green, tenacious stool. I do not wish to sound gross, but we normally don't ask people about bowel movements and the difficulty wiping after a bowel movement, especially when pregnant. Pregnant women are constipated because of the elevated progesterone levels that slow bowel transit, and then the enlarging uterus pressing posteriorly on the rectum. Excuse me, I'm sorry. Give me just 1 second. Can someone disconnect me, please? Okay. Intravenous iron does cause infusion reactions 1 to 3% of the time. I'm going to show you one. This is a real big deal because it is these infusion reactions and the mismanagement of them that fuel the folklore about intravenous iron danger that you all learned when you were in school. Severe hypersensitivity is vanishingly rare. It is actually less frequent with IV iron than it is with penicillin. So I'm not going to spend any time talking about the management of it, because if you're going to give an intravenous formulation of anything you need to be prepared to handle acute hypersensitivity. It's far more common with antibiotics, intravenous gamma globulin, and chemotherapy than with intravenous iron. Now, this is a pretty high quality meta-analysis of prospective studies comparing oral iron to placebo and intravenous iron. As you can see, all of the gray boxes are to the right of the unity bar. Okay, so I just don't leave all of you in suspense. I was in Portugal at the HHT meetings. I developed an acute viral or foodborne illness, and I thought I was being careful, but when I came back to the United States, I had acute renal failure. I'm getting better, but daily hydration definitely improves things, so I am now having my IV removed, and
Are you taking?
I will be fine. So anyway, getting back to the study, all the gray boxes are to the right of the unity bar. Now, there is an exception to this. If you use timed release iron or ferrosequels, that's iron surrounded by dialkyl sodium sulfosuccinate to protect the gut, there are far fewer gastrointestinal effects. But what there also is much less to no absorption, to a degree that these frequently used formulations, ferrosequels and slow FE, are proscribed by brand in the textbook of hematology. So if you must use one of those two formulations, you might even consider telling the patient to put it directly into the toilet once or twice a day, because you will get the same effect. Now, there's hope. Things are changing in the world of PO iron thanks to the wonderful work of Michael Zimmerman's group on the measurement of hepcidin and iron absorption after dosing. What you can see here, if you take it once a day or twice a day, you get the same amount of iron. So there's actually a reason not to give it more than once a day. But there's even a better reason to give it every other day. And I will actually show you the graphs in a second. Here is a table of taking oral iron consecutively for 14 days or on alternate days for 28 days. And what you can see, the alternate day paradigm gives you a 30% increment in net iron absorbed with a 50%, not shown on this table, decrement in side effects. Here's the reason. There is a change in plasma hepcidin after a single dose of oral iron. It peaks at about 8 hours. It is elevated at 24, but not at 48. And the absorption of iron is inversely proportional to the rise of hepcidin. And here it is. Total iron absorbed on alternate days is at least a third higher with significantly fewer side effects. But let's say it was exactly the same. It's still a home run for the alternate day paradigm because the toxicity is significantly reduced. So the conclusions of these three excellent studies, one in Blood by Moretti, one in one in Lancet Hematology by Stoffel, and one in the American Journal of Clinical Nutrition by Yoga, all from Michael Zimmerman's group, shows that large doses of iron trigger an acute hepcidin surge that reduces iron at 24 hours, but not at 48. And alternate day dosing increases absorption by 30 to 50% and reduces side effects. What I told you about the intravenous iron formulations is made sensible by this slide. This is a measurement of labile-free iron, the cause of the infusion reaction, which once again, I'm going to show you. You can see that iron sucrose and ferric gluconate have a significantly higher amount of labile-free iron, which triggers in a significant number of people complement, leading to an infusion reaction that consists of flushing and pressure in the chest. It is not anaphylaxis, it is tryptase negative. And these new formulations that I showed you just a few minutes ago have a markedly reduced amount of labile-free iron, even low molecular weight iron dextran, which can be given as a gram in 45 to 60 minutes, is significantly lower than the two iron salts, gluconate and sucrose. And it is for this reason that you can give a fairly large dose of a gram or even more in 15 to 60 minutes and not have any significant increment in adverse events. For iron safety, we have a marvelous meta-analysis published by Avni et al. After a Gavili's group, from a Gavili's group in Israel. 103 trials were performed between 1965 and 2013. Over 10,000 patients were treated and compared to 4,000 patients with oral iron, 1,300 with no iron, 3,300 with placebo. And it almost makes my skin crawl to say this, but 155 with intramuscular iron. Now, if I can take an aside for a second, IM iron is painful. It permanently stains the buttock. It requires multiple injections. It has been published to be associated with gluteal sarcomas. It is not safer, it is not more effective, and it is not less expensive. And for that reason, it should not be given to anyone at any time, for any reason, anywhere on the planet. And otherwise, I have no opinion about that. Overall, there was no increase in the risk of serious adverse events compared to any comparator, including placebo. That does not mean there weren't infusion reactions, which I think now for the 5th time I'm going to show you. There was no difference in efficacy among the formulations. Here is a forest plot that shows you the comparative safety. And this time, all of the boxes are to the right of the unity bar favoring safety. And this is an excellent paper in Mayo Clinic Proceedings in 2015. You have seen over the last few years a series of papers that look at surrogates for anaphylaxis, surrogates like spontaneous adverse event reporting, Medicare coding, World Health Organization coding. They are specious. They provide obfuscation of the truth and the data because they cannot capture the nature of the minor reaction. I'm going to show you the results of several head-to-head studies. Thousands of patients have been studied head-to-head. Iron sucrose to ferric carboxymaltose, ferromoxetol, and ferric dirisommaltose. Ferromoxetol to ferric carboxymaltose, dirisommaltose to ferric carboxymaltose. Each of them compared to each other. And the sine qua non for all of the studies is no difference. The Fairwarn study was published in the American Journal of Hematology. It compared iron sucrose to iron isomaltoside. They had a blinded adjudication committee to look at the composite hypersensitivity reactions. They did not know who received what. And once, as I told you, no difference in hypersensitivity reaction between the two. The FIRM study was a very interesting study because it supports the use of a gram, but not more than a gram in a single dose. Again, 2,000 patients randomized, double-blind, ferromoxetol to ferric carboxymaltose, performed in multiple countries around the world. Now, this may aggravate some of you. It certainly did me when we wrote the study, but 1,020 milligrams of ferromoxetol given as two 510 milligrams a week apart were compared to 1,500 of ferric carboxymaltose, or 50% more. This was FDA mandated because those are the approved methodologies in the United States. But we got a very interesting conclusion. The primary endpoint of hypersensitivity reactions and severe hypersensitivity reactions was again assessed by a blinded adjudication committee. No difference at all. But fascinating. Look at these slides. 50% more of ferric carboxymaltose at 5 weeks resulted in a clinically insignificant difference of 0.24 grams per deciliter, suggesting that doses of more than a gram are wasteful. The PHOSPHARE study compared FCM to ferric derissomaltose. Again, FDA mandated. A single infusion of a gram versus 2 infusions of ferric carboxymaltose. If this were done in Europe or Africa, it would be 1 infusion of ferric carboxymaltose because you have the more intelligent 500 or 1,000 milligram dose. Again, no difference. Here is a meta-analysis of all of the studies. You've all heard the term dextrane or non-dextrane containing formulations. This shows you how inappropriate that term is. There is simply no difference. This is an unadjusted 95%. Now, this is what I've been telling you you're going to see. So let me tell you how we got this. We have a very large study in India right now. It's funded by the World Health Organization, Children's Investment Funds, the Gates Foundation, and the National Institutes of Health. It's a second trimester study of oral versus IV iron in pregnancy, looking at baby outcomes and the incidence of preterm labor and small for gestational age babies. I was supposed to go to India to teach the doctors and nurses how to administer intravenous iron. And since I could not go because of COVID, Dr. Richard Derman, the Dean of Global Affairs at Thomas Jefferson University, paid a professional videographer to come to my office to film us giving IV iron. But for whatever reason, Lazarus flew into my office and gave me this wonderful video that I have been waiting for so long. I'm cutting out all of the portions of the video that show how we mix the bag and how we turn the IV on. But you're about to see a minor infusion reaction called the Fishbane reaction, misinterpreted as anaphylaxis, and that misinterpretation is responsible for 99% of the ostensible serious adverse events attributed to IV iron around the world. This is my infusion center. We have about 7,200 square feet. We have 13 chairs, and you can see one of the nurses just giving intravenous iron to patients. This young girl, a teenager, young woman, 19 years old, had no risk factors, heavy uterine bleeding, no multiple drug allergies, no asthma. You can see the IV iron hanging. We did not pre-medicate her, as we do with everyone. We start slowly. She did not get methylprednisolone or ranitidine or famotidine, which is what we give to people who are at risk. And as you can see, very slowly with observation, the intravenous iron is starting to go into her arm. That's her mother sitting there on the right. This is a standard bag with a standard infusion. We expected no issue. Now, this portion of my talk, these few seconds of delay, I guess I have to learn to say something intelligent during these few sections, but there's nothing to say. But here it is. Take a look at her. Look at her eyes. She's frightened. Look, her respiratory rate went up. Her face turned red. She's got pressure in the chest, She does not have wheezing. She does not have stridor. She does not have periorbital edema, and she is not in shock. And this is not anaphylaxis. Now, I'm going to stop this for a second. Pretend you didn't know this. Pretend you went to school and learned intravenous iron was dangerous, because you did. And pretend you thought this is impending anaphylaxis, because you would. And pretend that you gave epinephrine and diphenhydramine, because you would, which causes diaphoresis, hypotension, somnolence, tachycardia, shock, and ischemia. Who gets blamed? Not the epinephrine, not the Benadryl, but the iron. Now, watch what happens. What you're going to see takes place over 3 to 5 minutes. The infusion has been stopped. Fluids are being given. She will be pre-medicated with methylprednisolone and famotidine this time, but I must tell you, there's no prospective data that it makes a difference. I do it empirically because of a double-blind study that showed methylprednisolone eliminates the 24-hour arthralgias and myalgias that often occur with IV iron. Look at her face. The redness is all gone. You can see in her eyes that the anxiety is gone. She's on her phone. Pretty soon you will see her smile, and the lack of anxiety. But the real moral of the story is going to come in a few seconds. Here it is. Do you see the IV line in the back of the iron infusion? This young woman received the entire dose of the formulation that caused the reaction that I showed you. She did not end up going to the hospital with anaphylaxis. But if you use these specious surrogates, as has been done in a host of articles recently published, Medicare coding for interventions, you get a false sense of danger when indeed this is a minor self-limited reaction. So that's what I told you I would show you. Now, quickly, we will go through disease states. Oral iron actually makes inflammatory bowel disease worse. It has low absorption, limited efficacy, and it's directly toxic to the epithelium. And it is still standard in IBD, but it exacerbates intestinal inflammation and differentially affects bacterial communities in the metabolic landscape, negatively altering the microbiome, which is so important to these patients with this miserable disorder. And so IV iron is probably specific in terms of the replacement iron formulation. Here you have ferric carboxy maltose in IBD patients. Let me tell you, you can take iron dextran, ferromoxetol, or ferric maltose, and these graphs are identical. But the key is IV iron was better at any part of the study, but more importantly, none of the gastrointestinal perturbation that's ubiquitous with oral iron. In bariatric surgery, in normal individuals, iron has to be conjugated in the gut to vitamin C, amino acids, and sugars to make it protected from the massive alkaline secretions in the proximal duodenum, which will otherwise convert it to the unabsorbable ferric hydroxide, and it ends up in stool. Bariatric surgery patients can't do that. Oral iron should be proscribed. It has no credible expectation of working. And here's a group of people who rerouted their gut to lose weight. They must be iron sufficient to maintain activities. Here's an excellent study from Gaskire and obesity surgery in 2014 showing you the incidence of iron deficiency after bariatric surgery at 5 years, more than 70%. And these are people who were repleted with oral iron. I don't mean to be overly polemic, but I would say that makes it worthless. Here's a study that we just published in obesity surgery, looking at iron sucrose versus ferric maltose. in the prospective study that I showed you earlier, and you can see that there is a significant benefit in terms of speed of reaction, but it's really less important. Both of these formulations worked. Both of them, take a look at the endpoints, resulted in significant increments in hemoglobin, serum ferritin, and transferrin saturation. And the fact that ferric maltose did it faster is probably not clinically relevant, but the fact that it was able to do it with a single infusion compared to 4 to 7 infusion makes it very relevant. In pregnancy, I think we have the biggest unmet clinical need. The guidelines differ. United States Preventative Services Task Force says there's insufficient evidence for routine screening for supplementation at presentation in the absence of anemia. I will show you that that's in serious need of revisiting. The American College of Obstetrics and Gynecology Practice Bulletin says that intravenous iron is recommended if you can't tolerate or won't take moderate doses of oral iron. They have no recommendation for routine screening in non-anemic patients, and oral iron is still recommended frontline in the 3rd trimester. I heartily disagree. UK guidelines are a little better. Parenteral iron should be considered from the 2nd trimester onward, and all high-risk gravidas should be screened. I do agree, and in a marvelous paper in Blood by Chebby and Gafter-Gavili, our most prestigious hematology journal, intravenous iron for any oral intolerant 2nd or 3rd trimester patient, and for 2nd trimester gravidas with hemoglobins less than 10, and all in the 3rd. You do realize I'm talking about a significant paradigm shift in current guidelines. No PO iron in the 3rd trimester. I'm going to show you why. In the non-gravid state, the amount of iron you need is about the same as in the 1st trimester. But with the 5 to 10-fold increment in iron needed for the developing fetus and the placenta, it is not credible to assume that there's going to be adequate absorption of a formulation that causes significant toxicity in over 70% and does not provide adequate iron to the developing fetus. Maternal iron deficiency, not anemia, potentially affects fetal, neonatal, and childhood brain growth and development with adverse effects on myelination, neurotransmitters, and brain programming. And you can recognize this up to 19 years of age with cognitive function, memory, and even motor development. And iron deficiency in pregnancy has been associated with an increased risk of perinatal outcomes, including preterm death, preterm birth, low birth weight, and small for gestational age infants. In a prospective study of 2,400 women, Chow et al. Showed that perinatal iron supplementation reduces maternal anemia. It does indeed, iron deficiency and iron deficiency anemia. But 45% of the infants were deficient at birth. I would like to remind you that we do not screen our infants for iron deficiency. We screen them for phenylketonuria, which we should, which occurs in 1 in 25,000, and you can prevent the neurologic damage that occurs with appropriate screening, but we do not screen for iron deficiency, which occurs at a level associated with measurable developmental defects in 1 in 4. If that doesn't raise your hair, it should. Here is a graph given to me by Michael Georgetown, who is now head of the Institute for the Developing Brain and former chief of neonatology at the University of Minnesota. You can see here in the purple box that if iron deficiency is not fixed in the mother, by 2 weeks postpartum, all of these abnormalities that I just spoke to you about remain and can be measured up to age 19. And let me just say it again, we don't screen our babies for iron deficiency. We are in our study, and it is a primary endpoint. This is why it's so important. Here are the baby's ferritins compared to the mothers. You can see the mothers do get better, but there is no significant increment in fetal ferritins with mothers who are supplemented with oral iron. This is disturbing. It needs to be addressed. It's an unmet clinical need, and it continues to date. Infants who are at risk of neonatal iron deficiency are those from iron deficient mothers or previously treated for iron deficiency. Overweight, underweight, vegetarians, multips, IBD, HIV, or smokers, interpartum period of less than 6 months, or a history of abnormal uterine bleeding. Why don't we screen every presenting gravida? Here's data that says we should. This was a study I published in the Journal of Maternal and Fetal Medicine. We looked at 104 consecutive non-selected, non-anemic. Can I say that again? Non-anemic presenting gravidas. 42% were deficient based on serum ferritin, TSAT, or both. And you can see here, there's not even a difference in gravidity until you get to gravida 4, where the numbers go up significantly. A better study than mine, just published in Blood Advances from Canada, took a look at the prevalence of iron deficiency and screening. Only 45.6% were ever normal, and only 30.2% were never iron deficient or insufficient. When iron deficiency screening is done, it occurs early. It affects greater than 50% of pregnancies in Canada. 25% are severe, and 40% are completely missed. Does that bother you? It bothers me. Here is a study that looked at 299,000 mothers and their 566,000 offspring in a Scandinavian group, just published in the JAMA Psychiatry. Look at these figures. Anemia, mostly due to iron deficiency at any week of gestation, was associated with a statistically significant increment in spectrum, autism spectrum disorders. We don't screen non-anemic women. We don't. It's outrageous. You have treatment options. Oral iron works in the first trimester if tolerated, but 70% report significant distress. And the OBGYN literature says that the incidence of gastrointestinal side effects is unacceptably high. Thousands and thousands and thousands of patients have been published with intravenous iron. Not a single serious adverse event, not a single negative baby outcome. And yet the FDA and the European medical societies, European medicines agencies say that we need to monitor with fetal monitoring when we're giving IV iron, and that fetal death is a class complication of intravenous iron. I actually had a conference call with FDA about this, and their statement, completely reflective of their ignorance of the safety and administration of intravenous iron, said, well, IV iron can cause anaphylaxis, and anaphylaxis can cause fetal demise. I would like to remind you that penicillin can cause anaphylaxis, and yet penicillin doesn't carry that horrible warning. Can you imagine getting consent from a mother and say, here, we're going to fix your iron deficiency, but your baby could die? That's really going to be a selling point, isn't it? There was no reason for these irresponsible labelings. So what did I tell you today? I think these data support the convenience and safety of giving iron in a single setting. It should be administered as soon as there is intolerance. It should be given whenever it's known to be ineffective, like bariatric surgery and inflammatory bowel disease. And it should be administered if the hemoglobin is less than 10 in the second trimester and to everyone in the third. All pregnant women should be screened. It's irresponsible not to do it. All newborns should be screened. It's irresponsible not to do it. And compared with oral iron, IV iron has fewer side effects, is virtually always effective. It has 100% adherence because you cannot give it back once it's given. And these data really do call for large prospective studies, which is what we are doing, to compare IV and oral iron for the therapy of maternal iron deficiency anemia. And I am finished. Thank you for coming today. Thank you for listening. I'm all done.